Yeah, I can start, right? Yeah, good evening, everyone. In the last class, I had told about the spinal dysraphisms initially regarding the embryology and the spinal dysraphisms which are open and the closed spinal dysraphisms with subcutaneous mass. In this class, I will be talking about the closed spinal dysraphisms without the subcutaneous mass. Before starting this class, I want to just refresh on the embryology part because the embryology is the base to understand all these abnormalities. So this is the zygote when it gets implanted to the syncytial trophoblast. There will be double layered uh, epiblastic and hypoblastic zygote will be there, which will be covered by the amnion, and this is the yolk sac. And once the then the process of gastrulation starts. That is the conversion of the bilaminar disc to the trilaminar disc. Um, this one. So what happens is initially there will be formation of the primitive streak, which is nothing but the thickening of the epiblastic cells which are in the midline. They go towards the buccopharyngeal membrane, and the cranial end of this there will be a primitive node. This primitive node will have a pit within it, that is called the primitive pit. So this is the primitive node or the Hensen's node. So through the primitive pit, the epiblastic cells they invaginate and to form the mesodermic cells. So these mesodermic cells they place themselves between the epiblast and the hypoblastic cells, and the trilaminar disc will be formed. And the medial one, that is the cells of the mesoderm which are in the midline, they are the one which forms the notochord. This I had told in the previous class. And the notochord initially it will be two notochords which fuse in the midline to form a single notochord. Before the full notochord, the tube will be there. That tube will communicate with the amnion through the primitive pit of the Hensen's node, and with the yolk sac through the notochordal canal. So this notochordal canal will be there for a couple of days, then it will disappear. If there is a persistence of the notochordal canal, there will be a communication between the amnion and the yolk sac, and that is the one which will give rise to the dorsal neuroenteric cysts. Okay, then after that, that is the process of primary neurulation will come. That is the thickening of the epiblastic cells forming the neural plate dorsal to the notochord. This neural plate folds upon itself to form the neural folds. The neural folds fuse together to form the neural tube. Once the neural tube is formed, the epidermal cells, which are actually they are formed from the neuroectoderm, they disjunct from the neuroectoderm, and the mesodermal cells they position themselves in between the neural tube and the epidermal cells. These epidermal cells subsequently will give rise to the skin and the subcutaneous tissue. And the mesoderm, of course, the layering, that is the muscle and the bony tissues will be formed by that. And the neural tube there will be formed. This neural tube, this process is called the primary neurulation. Then it is followed by the secondary neurulation or the retrogressive differentiation. So in this there will be a lower inner cell mass. This inner cell mass will cannulate itself to form the which communicates with the primary neural tube canal, that and also this inner cell mass they form, that is the secondary neural tube. Then it forms the eventual the spinal cord at the filum terminale, and the conus is formed by the secondary neurulation. So this is eventually the initial embryology. Now coming to the classification, I had dealt about this classification in the earlier class, and up to here I had told. Now in this class I will be talking about the spinal dysraphisms without the subcutaneous mass, and these are the things that are included in that. Coming to the foremost of that is the simple dysraphic states, which are nothing but the intradural lipomas, the pilar lipomas, tight filum terminale, dermal sinuses, and the persistent terminal ventricle. In the intradural lipoma, as I had earlier told, it is due to the early disjunction. That is, before the closure of the neural tube, the epidermal tissue will disjunct itself from the neuroectoderm. Subsequently, the the mesodermal cells, they enter towards the neural tube to form the intradural lipoma, and epidermal tissue will eventually closes itself. So in the intradural lipoma, it refers to the lipoma that is located along the dorsal midline that is contained within the dural sac. So this will be within the dural sac because the dural coverings are formed by the mesodermal cells. So there won't be open spinal dysraphism, means it will not be open to the outside, commonly located in the lumbosacral level. You can see it in the cervical region also. So this is what that eventually forms this lipoma, which is iso-intense to the subcutaneous fat in all the sequences, that is hyperintense on both T1 and T2 weighted images. So this is one intradural lipoma. You can see there is a large intradural lipoma which is located at the cervicothoracic level, which is hyperintense on both T1 and T2 weighted images. Here, the spinal cord, as you are seeing, it is quite compressed, and also they are usually, this neural tube will not be formed at this level. The neural folds, they will be widely placed, and there won't be proper formation of the spinal cord at this level. And this is the intradural lipoma. Coming to the filar lipoma, this is nothing but the secondary neurulation abnormality due to the fibrolipomatous thickening of the filum terminale. As we all know, filum terminale is both intradural as well as extradural. So the whole length of the or part of the filum terminale may be involved by this lipoma. So if you are having filum terminale lipoma along its entire extent, it is both intradural and extradural. This is one example. You can see the hyperintensity along the dorsal part of the spinal canal in the lower lumbar level as well as the sacral level, and this is hyperintense on T1, and this is the T1 weighted image, and this is the T2 weighted image showing hyperintensity on T1 weighted images. So this may be associated with the low lying cord, the filar lipoma. At that time it will become more significant. Otherwise it's not that significant. It may be an incidental finding. In a tight filum terminale, this is nothing but the short and the stout filum terminale, which the filum terminale is hypertrophic and it is shorter in length, and this produces tethering, and subsequently there will be impaired ascent of the conus medullaris. So all these can lead to the formation of the syrinx in the spinal cord at various levels. The abnormality is more frequent in patients with other malformations such as Diastematomyelia, or there may be dermal sinuses. So this is one tight filum terminale. You can see this is the phyla that is at the level of the lower lumbar level. It is short and it is stout, and it is attached to the posterior part of the spinal covering. So this is the tight filum terminale, where the conus is the spinal cord is ending at the lower level. That is, anything that is below L3 level, you have to consider it as abnormal irrespective of the age. So and subsequently you can see there is a syrinx. Of course the syrinx is smaller in size at this level, at this point of time. Coming to the dermal sinuses, this is nothing but the epithelial line fistula that extends inwards from the skin surface and can connect with the CNS and its meningeal coverings. What you see on the subcutaneous tissue is only a dimple which may continues as a dermal sinus tract, and it differs from the sacrococcygeal fistula. I will be telling about that in the subsequent slide. What is more important is this may be associated with other abnormalities like tight filum terminale or the filar lipoma or a low-lying cord. And because of this, and the tethering of the cord, because of this, and it may also communicate with the spinal canal at the various levels. So there may be, in the normal imaging, we may see some signal changes in the lower part of the spinal cord, or in the entire level. We will tend to come across this type of imaging in the younger age group, and we tend to misinterpret as some demyelination or a transverse myelitis, which could be infectious. So we should be careful in such scenarios to actually look at the signal changes, whether they are secondary to demyelination or whether it is due to the infection which may be associated with the dermal sinus. Because I've come across one case which I always tell in my meetings. One child who was around 8-year-old child had a dermal sinus that was missed clinically, and the child had come for the imaging. The imaging was reported as demyelination in by someone. So subsequently, steroids were given for the child, and it has led to the I have not seen such a type of abscess which is involving the entire cord. It is like an intramedullary abscess secondary to the infection, which is exacerbated by the treating with the steroids. So we should be very careful for any signal changes, especially in the childhood, in the changes in the spinal cord when it is at the means lower thoracic and the lumbar level. In such scenarios, you have to look for the dermal sinus, probably because the reason is it may be all secondary to the infection that has come to the dermal sinus and has led to the signal changes within the spinal cord. So that is regarding the dermal sinus. You have to differentiate with the simple and the low risk dimple with the high risk dimple for dysraphisms. In the low risk, it is usually coccygeal in position, whereas in the high risk, it is lumbosacral, and usually will have a cutaneous base which is visible in the low risk, and a deep dimple that will be present in the high risk dimple for dysraphisms. And coming to the other thing, the persistent terminal ventricle, it is nothing but the ependymal lined cavity within the conus medullaris. So this is and the ependymal lined conus medullaris. It is there, which will be above the level of the phylum. Whereas if the close differential diagnosis for the persistent terminal ventricle is myelocystocele, which will be terminal myelocystocele, which is nothing but which is usually seen at the phylar level, at the lower level. So in the terminal myelocystocele, it will be below the level of the conus medullaris, whereas in the persistent terminal ventricle, it will be at the level of the conus medullaris, and it is due to the incomplete regression of the terminal ventricle during the secondary neurulation. So the key imaging feature is you will see a ependymal lined cyst which is seen at the conus medullaris. It will not enhance us on contrast, and usually will be seen above the level of the phyla. So the differentiating feature, as I earlier told, you have to differentiate it from myelocystocele. So other thing is closed spinal dysraphisms without a subcutaneous mass, which are due to the notochordal developmental abnormalities. You can divide that into two categories. One is the disorders of midline notochordal integration and the disorders of notochordal formation. So in the midline notochordal the various anomalies the centric fistula, neuroenteric cyst, and the diastematomyelia. So coming to that is, see, this is in the notochordal notochordal integration. I found two notochords will be there, which they eventually fuse together to form a single notochord, and which will have a tube inside, and later it become a solid cord like. So when there is a persistence of the tube, that is the neuroenteric canal, notochordal canal, when there is a persistence of that, then it will give rise to the neuroenteric cyst and the dorsal enteric fistula because this is at the various level of gradations, means various gradation. If the in a dorsal enteric fistula, the entire notochordal canal will be persistent, whereas in a neuroenteric cyst, a part of the notochordal canal is persistent, and eventually it will give rise to the neuroenteric cyst, which is lined by ependymal cells. Mm. So, in a dorsal enteric fistula occurs when there is abnormal communication between the skin surface and the bowel. So, you will this entire thing, this the bowel and the skin surface, this entire in entirety, this dorsal enteric fistula will be present in a persistent neuroenteric cyst, persistent notochordal canal in its entirety. Whereas in a neuroenteric cyst, as I told you, it is a more localized form, the dorsal enteric fistula. So this is one neuroenteric cyst. You can see this is ventrally located at the level of the thoracic cord, and this is iso intense to the CSF in all the sequences. So this may be or may not be associated with vertebral anomalies. So that is what that you see in a neuroenteric cyst. Whereas usually it will not enhance with contrast. Sometimes when it is seen in the spinal, I mean the cranial level, usually in the brainstem level, you can see the neuroenteric cyst. And if you take MR spectroscopy from this cyst, it will have a Na like peak, that is a N-acetyl aspartic acid. Usually it is secondary to N-acetyl glycosamine within that neuroenteric cyst. The same pathology will be there in the bronchogenic cyst also. Means they all in a same family of cysts which are embryologically related. Bronchogenic cyst, neuroenteric cyst at various levels. Now coming to the dorsal enteric fistula, this is one example. This is iso-intense to the CSF in all sequences. Here associated vertebral anomalies are there. It can be hypoplasia or aplasia of the associated vertebra. This is not a complete dorsal enteric fistula. But you can see that there is a butterfly vertebra in midline. There is the anteriorly the body is not fused, and you can see the cystic portion that is going through the vertebral body, and this is where the bowel is going to come. But I cannot demonstrate in this. There is a complete persistence of the dorsal enteric fistula. So if there is a persistent throughout its length, the notochordal canal, if it is existing, it will give rise to the dorsal enteric fistula. If it is at the some localized portion, when it is only persisting, it will give rise to the neuroenteric cyst. Of course, it can be associated with various other anomalies of the vertebra, both anteriorly as well as posteriorly. So this is one which I have taken from the literature, where it is communicating with the bowel, where this is one cyst which is within the spinal canal. Through the vertebral body, it is going through the to the cyst that is communicating with the bowel. Now coming to the other entity with the midline notochordal integration is, as I told earlier, this notochord, which is 2 in numbers, it can remain as 2 in numbers, and this influences the formation of two chords. So when the notochord is persistent as 2 without the fusion, in the future it give rise to two spinal cords. So the separation of spinal cord into two hemichords is called as diastematomyelia. There are two types in that, Pang type 1 and Pang type 2. In Pang type 1, the two hemichords are located within the individual dural tubes separated by an osseous or cartilaginous septum. Whereas in Pang type 2, there will be single dural tube covering containing two hemichords. So there will be single subarachnoid space, only separated by fibrous septum. Like this is the case. So this is the single dural covering, two hemichords are present, and the single CSF space. This is the Pang type 2, whereas here you can see there is a Pang type 1. The fibrous, the cartilaginous or the bony septum is persistent. Two dural tubes are there. You can see the CSF around each tube. This is the Pang type 1 diastematomyelia. Of course, it can be associated with lipomyelomeningocele or hemimyelomeningocele, like that. It is separate to each cord individually. Now coming to the disorders of notochordal formation. In the disorders of notochordal formation, you have caudal regression syndromes and segmental spinal dysgenesis. In a normal development, you can see this is the notochord, that is the black thing. This will be the neuroectoderm, and the inferior part is the endoderm. So this is the yolk sac. This is the amnion, and that superiorly, and the yolk sac inferiorly. In a caudal regression syndrome, there is a disorder of both the primary as well as the secondary neurulation. So when that is associated with both caudal, that will give rise to the caudal regression syndrome. In segmental spinal dysgenesis, there will be disorder of the spinal cord formation secondary to hypoplasia of the notochord at various levels. I will be telling about that. So in a caudal agenesis, as I told earlier, it refers to the total or partial agenesis of the spinal column, may be associated with the following, like anal imperforation, genital abnormalities, then renal dysplasia, pulmonary hypoplasia, or limb abnormalities. And there are two types in that. Type 1 is the high type, for the low type. The other type is so caudal agenesis. I told you that it is due to the not only the tapered is or double of the node will develop. So there is interference in both processes of primary and secondary. So depending on severity of origin, the eventual degree of vertebral aplasia will range from either absence of the coccyx to or the lower mid-sacrum to aplasia of all coccygeal, sacral, lumbar, and lower thoracic vertebra. But usually, in majority of the cases, you will see the vertebra up to L5, maybe up to S2, and below that the vertebra may not be seen. But of course, the spinal cord will be involved, and the spinal cord will be there will not be conus, and the spinal cord will be ending abruptly like a club-shaped spinal cord. So this abrupt ending of the spinal cord, along with the absence of the vertebral bodies, vertebral column, in fact, below the L5 or the S2, will you call it as caudal regression syndrome type 1. So there will club-shaped spinal cord. It may be associated with tethering of the cord. So club-shaped spinal cord with syrinx and absence of the vertebrae, especially the lower lumbar and sacral and the coccygeal vertebra, goes to the caudal regression syndrome type 1. This is the CT scan film. You can see below the L5, it is not present. Now, caudal agenesis type 2, in the agenesis type 2, that is a regression syndrome type 2, usually the primary neurulation is not affected, but there is interference with the process of the secondary neurulation. So you may not be able to see the coccygeal vertebra, and below the S4 vertebra usually will not be present in that, but the spinal cord will be formed normally in such cases. So this will be a case of caudal regression syndrome type 2, where the lower sacral and the coccygeal vertebra will not be present, and the spinal cord will be formed normally. But in these cases, there may be tethering of the cord, due to which there will be low lying of the cord, and it can lead to abnormalities secondary to that. So this is the axial image. You can see the cord is seen even at the sacral level at this point. That is due to the tethering and low lying of the cord. Coming to the segmental spinal dysgenesis, the definition includes segmental agenesis or dysgenesis of the lumbar or thoracolumbar spine, segmental abnormality of the underlying spinal cord and the nerve roots, congenital paraplegia or paraparesis, and the congenital lower limb deformities. These are the various definitions that are various abnormalities that are included under the definition of segmental spinal dysgenesis. So there are two distinct types in that, type 1 and type 2. in both the types there will be abnormality of the spinal cord and the adjacent spinal column, that is the vertebral bodies and and the other elements of the vertebra may be involved. So in type 1, this is the most severe case. The spinal canal at the level of the abnormality is thoroughly absent, and the bony spine is focally aplastic due to the absence of one or more vertebra. As a result, the spine and the spinal cord are cut into two. So, in a segmental spinal dysgenesis, which is a severe case, which severe variant, in a type 1, the spinal cord and the spinal column are cut into two. So you will have two disconnected upper and the lower spinal segments, each containing a spinal cord segment, which are reciprocally displayed so that the acute angle kyphosis results and a bony spur is palpable along the child's back. So this is what you are seeing. We have a case here. You can see the spinal cord is abruptly ending at this level. Spinal cord is like a club shaped. It is ending abruptly at the lower thoracic level. You are not seeing the vertebral bodies in between at in near the edges, but you are seeing the spinal uh, cord at the and the sacral vertebral bodies you can see. So this is the corresponding CT scan image of the same child. You can see the intervening vertebral bodies are absent, and there is a kyphoscoliotic deformity of this spinal canal. So that is the those are the sagittal images. These are the axial images. You can see this is at the splenic level. You can see this is the spinal cord that are seen, which is having a syrinx. So at the kidney level, you are in the axial sections. You are not actually seeing the spinal cord. But when you come down, this is at the sacral level. You can see the spinal cord that is present, and there is no intervening at this one. There will not be any vertebral bodies that are present. Coming to the type 2 SSDs, this is a less severe case. There is focal hypoplasia of the spinal cord, which will therefore appear, means due to the hypoplasia it appears thinner than normal on MRI studies. So there is no complete disconnection of either the vertebral bodies or the spinal cord in type 2 SSDs. Of course, there may be associated bony abnormalities like bony stenosis of the spinal canal, vertebral butterfly vertebra or segmentation defects may be associated. But the spinal cord as such, it is smaller in size at the involved level, but it is continuous. It is continuously present, and there may be associated other vertebral body abnormalities that are associated with it in type 2 SSDs. So this is one the picture I have taken from the literature. You can see there is hypoplasia of the spinal cord as such, but the spinal column is present, which may be associated with some segmentation anomalies. Otherwise, it will not be totally absent. So this is where there will be hypoplasia and the normal cord is seen. This also may be associated with tethering and low lying of the cord. So with this, I would conclude this talk on the spinal dysraphisms. So you can easily take it like you need to know the embryology. Embryology is very much essential to understand various spinal dysraphic states. You need to have various classifications are present, but you stick on to one and you follow the same. So to simplify, you can make it as open spinal dysraphisms or the closed spinal dysraphisms. In the open spinal dysraphisms, you have myelomeningocele, meaning myelocele as such, or myeloschisis, hemimyelomeningocele or hemimyeloschisis. In the closed spinal dysraphism with subcutaneous mass and without subcutaneous mass, various means pathologies will come under, as I had enumerated earlier. So with this, I would like to end the talk And if there are any questions, I would like to take it. Thank you.